I have a soft spot for all therapists and how interested you are in what we do. And it's important to me that you have a pretty decent understanding of what we do because you guys get to see our patients so much more than we see them. So having a basic understanding of the medications, the diagnoses, the medical things that could be going on instead is just helpful. It's helpful for everyone. And it's not practicing outside your scope. It's nothing like that. It's just being able to share information that's helpful for making treatment decisions, whether it's in therapy or for your client to decide where they need to go, who they need to talk to next. So I love this. I think this is fantastic. If a person stays in a state of psychosis for a long period, they often don't recover to the last baseline and kill healthy brain matter. Is there research on that? What has been your experience in working with patients who present with chronic symptoms of psychosis? We don't want people to stay in a psychotic episode any longer than they have to be. Treating fast and early and trying to maintain that for as long as possible, for sure. So brain death or neuron death, I think we see that more in mania when the patients are like kind of on fire and they're not resting their brains. But it's certainly long-term psychosis, it doesn't get better over time. The more time you spend in a psychotic episode or the more time spent in psychosis overall, over time, the worse the symptoms will be and the harder it will be to treat. That's one of the things with medication. We want to treat people early and we want them to stay on meds because it just overall their prognosis is much better and their functioning usually is better as well. So I have a broad range of patients presenting with chronic psychosis. So I can think of a couple of patients I have right now that I've never seen them psychotic. I have no idea what their psychosis looks like. I'm not even sure if they have an accurate diagnosis. I'm thinking of two particular patients, and both of these patients are very med compliant and don't even want to think about going off their medication. Like whatever their experience was, and they've articulated that to me, but I never saw it in person. It was bad enough that they don't want to do anything different with medication. They just want to maintain their meds and never go through that experience again. And for at least those two patients, I know it's been over 5 years for each of them since they've had any episodes at all. So I've never seen them in episode, and these two patients are totally sold on the idea that they're going to just keep taking the medication and hope it never happens again. And I love that. There's a little part of my brain that's like, but what if it's wrong? What if it wasn't? But you know what? They're happy to take the medication. They get their checkups. Like neither one of them are on anything for diabetes or anything. One of them is a little bit overweight. The other one is very careful with his diet and his health. So it is something to be aware of. Obviously, you don't want people to take a medication that has long-term medical risks if they don't need it, but I'm not going to test it. I'm not going to be the lady that pulls away the meds and says, let's just see what happens. Can untreated STDs cause psychosis? So it's not as common now, but HIV has psychosis associated with it, and syphilis. But in general, the most common STDs untreated do not. But it is a good reason to get checked. For women, it's more common to have an STD and not know it. Most men who have an STD are aware of it and often seek treatment because they don't like the experience of having the STD. So with those two, HIV is manageable and syphilis is treatable. So these are things that, yeah, they should be a consideration. Lower on the list now than it used to be. I'll talk a little bit about the side effects of second generation antipsychotics because people complain about them. A big thing with the newer antipsychotic medications is weight gain. A lot of patients will complain about weight gain, and we consent all our patients when we put them on medications, but people may be all level of function when we're consenting them for medication. And also it can be stressful to sit with a doctor and have them explain all this stuff about the medication, so they don't necessarily hear all the things. And many of them are shocked to find out that the medication makes them hungry or causes weight gain, and that can be really upsetting. There are different medications that may have weight gain as a less likely thing, but they still all can potentially cause weight gain. I tend to see olanzapine, Zyprexa, as one of the worst, and the second worst being Seroquel or quetiapine. Those two are really bad with weight gain. And then I think followed maybe by Risperdal or Risperidone. So that's a huge pain. And then a lot of patients also feel really sedated on some of these medications. So that's another thing. If people feel slowed down or foggy, it also might just be the basic sedation. So they feel tired. Some antipsychotics get dosed twice a day, and there isn't always a really good indication for that. So sometimes maybe the patient can talk to their provider, whoever's prescribing their medication, about just getting it dosed once a day at night instead of having to take a dose in the morning, because most of these medications last for longer than 24 hours, so they don't have to be dosed twice daily unless there's a really specific reason for that. So that can help. We know that eating is one of the most pleasurable things people can do. Like, they've done studies with dopamine spikes, and people spike like crazy when they feel hungry, and then they have that first bite of something, like dopamine gets so high. So we're giving medications that are specifically messing with the dopamine system. So already you're getting some sort of unnatural responses there, especially for patients that are already anhedonic, they don't feel good. Eating is something that your brain, your very old brain from evolution, knows that eating feels good because it means you're going to live another day. So I think it's physiologic. It's not so much just like the feel good piece, but these brains are craving something that feels good, and eating can stand in for some of that. We know the medications cause weight gain, but there's a lot of different minutia about like the mechanisms for how this works, and I think overeating is part of it. Antipsychotics usually don't cause as much sexual dysfunction as like SSRIs, so the antidepressant, anti-anxiety medications, but pretty much all mental health medications can affect sexual function. The main way we can manage that is, for a lot of depressed patients, we use Wellbutrin or bupropion. That's an antidepressant that is more activating, and it doesn't work on serotonin, it works on dopamine. So in some cases, that wouldn't be appropriate for somebody who's taking a dopamine blocker, like an antipsychotic, but it can provide some benefit with sexual side effects. Sometimes, if it's the right problem, we can prescribe like Cialis or Viagra or something for that, but that's not always the problem. The answer is, if it doesn't go away, if the patient has been on the medication for at least 3 months and it's still a problem, that's a risk-benefit discussion to have with the prescriber of whether or not it's worth trying a different medication, because just because one medication is causing sexual side effects for a patient doesn't mean all the medications in that class will cause that same side effect. We see it all the time with SSRIs too. Somebody may have a problem with one SSRI like Zoloft, but then they switch to Lexapro and they don't have that problem anymore. So it's kind of a little bit of tinkering. But because psychosis is so scary, it would require a discussion with the prescriber about risk-benefit. Motivational interviewing techniques can be something that's really helpful here. So just trying to understand the circumstances around why someone thinks they don't have a condition, or why they're against taking medication for something that they think they don't have. If it's the medication itself, just the idea of taking a crazy pill, sometimes that can be reframed in a way that makes it seem not so terrible. I have plenty of patients that will take all kinds of awful stuff that is not mental health medication, but can cause more risk than what they do with my medications that actually are generally pretty safe. So there's that disconnect sort of between like why somebody would want to or not want to take medication, whether or not they have something. And so sometimes spinning something a little bit differently, so it's like, well, you don't really see these things. I see this, and this is what I'm concerned about. Maybe if we just tried this thing, then I would feel more comfortable, you would feel more comfortable, and the whole situation would be better. Obviously, I have to consent everyone. I have to provide informed consent, so I can't make stuff up. I can't coerce a patient into taking something, but I will say I definitely spin lots of things in such a way that it feels more beneficial than me just saying like, but you're schizophrenic, so you have to take this. Because maybe there's something in there and you're not sure what thing will ping for somebody for them to be like, yes, that's the thing. It is a tricky thing, and motivational interviewing can be helpful over time. It's not usually something you're going to do in one session or one meeting, but it can help people come around to the idea of seeing the benefits and maybe that the risks are not what they thought they were. Let me just say this then about helping patients with medication compliance. A lot of times they'll tell you that they don't want to take their meds or that they're not taking them the way they're supposed to, and that's okay. They can tell me that too, but they often don't, and I'll make changes to their medications not knowing that they're not taking them the way they say they're taking them. So if you can help them understand why compliance is important and troubleshoot some of the problems that they're having. If they're having side effects to the medication and it's a newer medication, they just started it, most side effects should be tolerable. They should be mild, not even beyond moderate. Like they might be moderate for a couple of days, but like an upset stomach, not like vomiting crazy for like 3 days straight. That's severe. So mild to moderate symptoms, they should be tolerable, and have them jot this stuff down. Have them make a little like thing in their phone, or they can make a little piece of paper and keep track of, is this really a side effect? Is it going away? Is it from the medication, or is it because you're having like a fight with your spouse? There are a lot of things that can come into play when patients want to say the medication is not working or the medication is causing problems. We really want to look at that as thoroughly as possible because there's only so many medications we could prescribe. So talking to them about compliance, about how long it takes to see the positive effects of the medication. If they do have side effects, it means their body's processing the medication. It's not like something I want to be excited about, but it's good. The medication is getting into their system. It is getting broken down by their body, and hopefully the side effects will go away and then the positives will kick in. Not taking it multiple times a day, if they're supposed to take something twice a day and they're only taking it once a day, it may be completely ineffective that way. Some medications need to be taken twice a day to maintain the level. And if they're going like down because they're missing a dose every time, that could make them feel worse. Helping them set alarms to remember how to take it, or talking to them about, well, what do you do that you could set this thing to remind you to do whatever. Any kind of stuff that you can troubleshoot with compliance for medication. And then just telling their prescriber, I can't take it like this. This is how I've been taking it. Or I know you told me to stop this other medication when I started this one, but now I'm taking them both. Because we can't make good decisions about care if we don't know what they're actually doing. So those kinds of little things that it might not seem important, or it might feel like it's outside your scope, it's really not. It's just maintaining the thing that they are already supposed to be doing that they're struggling with. So anything you can do to troubleshoot that and make that a better experience for them with taking medication, and for just being open with their prescriber about what they're actually doing with their medications and what the problem is so that we can try to fix it. Okay. I solved everybody's problems. Look at that. All your clients are cured. We're good. All right. Well, maybe you guys have some questions about something else someday, and you can let me know and I'll pop in.